Right, so I'm going to do much the same as I did last week. We're going to be looking at me taking this exam. I'll answer it as I would if somebody asked me the same question. So, we had a 29-year-old runner who was female, gradual onset of retropatellar pain, apparently without cause. The pain got bad enough for her to stop running for the previous 4 days. The onset was about 3 weeks back. The knee is getting, the pain is under the patella and it's getting worse. It's getting worse over time and during the run. So the more she runs, the worse the pain gets at that time, but overall it's getting worse. But since she stopped running, the thing has eased off some, and she's still got problems with it, but it's nowhere near as acute as it was. And she can't think of any cause other than the fact that she runs for about 4 miles 6 days a week. That's it. That's what we got. So these are my questions. My thought is this is retropatellar pain syndrome, and these are my questions to her. Does your knee get stiff and painful after you've been sitting for some time? So-called movie sign. The answer to that would be yes. Is there any swelling in the area? When it's painful, it gets a bit puffy on the inside of the kneecap there, but not the whole knee, just that area around the inside of the kneecap. Okay, what can't you do? Can't run. All right. What aggravates it? Running. What about stairs? Yeah, they hurt. What, going up, going down are about the same. Coming downstairs is worse than going up. So everything here is supporting the fact that this is a retropatellar pain syndrome. Now, that would be my H1. My differential on this one, well, I haven't finished the diagnosis. So my first test would be to palpate the fusion and also grind the patella and palpate beneath the patella, and I'm expecting to find pain on grinding, particularly over a certain area, possibly crevitus, and tenderness on palpation, which occurred under the superior and middle facets on the medial side of the kneecap. There's my diagnosis. It's retropatellar pain syndrome. My bias and error correction would be, first, this could be coming from the tibiofemoral joint, or the tibiofemoral joint could be an additional problem. Negative differentials would be a quadrant test, which is negative. That leaves me with referred pain. So it could be a patellar ligament problem, patellar retinaculum problem on that side. So layer palpation would help me do that. So I'm looking at superficial palpation being painful rather than me actually pushing and getting underneath it. If that's true, then I'll stretch the patella both laterally and medially to stretch the horizontal and vertical bands of the lateral retinaculum. Don't need to do it. So the next thing is referred, but we know it's local simply because the quadrant test was positive. So that's my diagnosis. I'm perfectly happy with this retropatellar pain syndrome. I can't say it's chondromalacia. I've got no visual evidence of that. So it's just retropatellar pain syndrome. So what did we achieve? Okay, the pain is coming from the undersurface of the patella. And the best we can do is say it's retropatellar pain syndrome. And we got that from the fact that the grind test was positive, palpation was positive, the ligament, the medial ligaments weren't, the lateral ligaments weren't, medial ligaments weren't, yeah, that gave us that diagnosis. We also found out that the knee wasn't contributing, the tibiofemoral joint wasn't contributing by the negative quadrant test, and that there is inflammation present via the puffiness, the aching after exercise, and so on. We also know there's a hidden etiology because her cause, her immediate trigger was running, but she's been doing that for some time and nothing changed. It wasn't an injury or anything else. The other thing we can say is because there wasn't a previous history of the knee, of an injury to the knee, then the etiology is actually hidden. If there was an injury there, then anything could happen. You could have reflex inhibition happening, segmental facilitation, all of which may have caused this problem, and then the etiology becomes obvious. It was the previous injury. But in this case, there wasn't any, so we have an hidden etiology and we need to look for it. So let's have a look at the diagnostic process in diagram form. What we have is right patellar pain. There's no doubt about it. The pain is over the patella. It's not saying that it comes from the patella, but it's over the patella. So what we also found was in the subjective exam, we had a positive movie sign, pain coming downstairs, which is really typical of retropatellar pain syndrome because there's more stress through an eccentric contraction than a concentric. There was puffiness after exercise, and we also found that there was tenderness on palpation under the patella. I forgot to put that on there, but there was. Or actually, I moved it over, I think. Anyway, the grind test was positive. Objectively, the grind test was positive. It was tender, supramedial, and middle for sets. The knee had full range of motion. The quadrant was negative, and we have negative contractile tests. So our diagnosis becomes retropatellar pain syndrome. The differential diagnosis is it could be coming from lumbar side, could be referred from the hip, or it could be the tibiofemoral joint. As it gets sort our way through this, do PAs on the spine, quadrant tests the hip, quadrant tests the knee, all of which were negative. So our diagnosis basically stands. Okay, so let's have a look at the etiology. Now this can be neurophysiological, maybe soft neurological, or mechanical. Now with the lower limb, mechanical forces dominate everything else. While neurophysiological and neurological problems may contribute, they're unlikely to be the leading cause of the problem. Mostly it's going to be mechanical. So that's where I'm going to start with this. So we'll look at the Q angle in standing. And as I say, the Q angle basically indicates whether or not there's an excessive medial force of valgus force acting on the knee. So if you're an increased Q angle, it's because the leg is basically medially rotated and abducted at the knee. So if we look at specifically what this means, it means there is an increased valgus force. During the quad contraction, because of the increased Q angle, the patella is pulled laterally, so there's a lateral resultant instead of a neutral resultant, because what normally happens is there is a greater lateral vector anyway, but the valgus medialis is coming from a horizontal direction, counters it, and it keeps this finishing up pretty much vertical to where it was, but now it gets pulled laterally, which also means that the lateral side of the patella comes up against the lateral femoral condyle, and there's increased pressure there, and there's decreased pressure on the medial side. So either of these two sides could undergo degeneration, either the lateral side because of the pressure, or the failure of nutrition on the medial side. So you can get problems on either side of the knee from this. Now, cause of the Q angle, long leg's a big one. But again, long leg tells you what to look at. Now in this case what we've found is that gait didn't show a leg length discrepancy, so you can't be sure if there's a long leg or not. So what you do is you look for causes of long leg, hip and ankle in particular. Now if you don't find those, then you look for causes of a short leg where there is compensation going on, so that's going to be the foot. So either way you end up on that leg somewhere. So this is going to be caused by ankle or hip biomechanical dysfunctions and hypomobility, making it long and then the medial valgus force being stressful, or a valgus instability in of itself. And then you have to wonder where that came from, as there was no trauma to the knee. The long leg, the Q angle, can also be increased because of the posterior rotation of the innominate and lateral rotation, but it's a very minor cause of this. It's not really big enough rotation there to make up for this. As I say, it can also be a short leg caused by a collapsed foot. So next thing I would do is look at weight bearing tracking tests, that's mechanical. So this is where you get them to squat over their feet. Don't get them to squat all the way there, just so their knees go over their feet. Look where the knee is in relation to the feet, should be over about a second or third metatarsal, and then get them to laterally rotate the legs without rolling onto the side of the feet, and they should be able to bring the knees over the lateral border. Now if they can't do that, this is almost certainly because the leg, the foot won't allow it to happen. So this is where you're going to look when that happens. So it's a screening test, and it's not just a screening test, it's a directional test. It tells you where to look. What we found in this case was that the ankle had subluxed, and it gave you a long leg that overcompensated, at least partly because of the increased Q angle, the adduction of the knee. We can then look at neurophysiological and neurological problems, and that's going to be indicated by the non-weight bearing tracking test, where the quads can't control the patella. You get maltracking and it gets pulled laterally. Again, because the valgus medialis atrophies faster than the rest of this, is obviously because of the atrophy, it's going to make it weaker. And this is because of the number of motor neurons in it, probably. So you palpate the muscle for atrophy. You can test strength tests as you did, that is in prone with the knee flex and forcing it. And the chances are that you're going to pick some weakness up there, but it's not going to be as much as in the valgus medialis, almost certainly. So what you can expect to see there is slight non-fatigable weakness. You then test L3 for segmental facilitation, and that's going to have to be done really through the multividae. We're going to see if they're hypertonic, because there really aren't any other muscles. Hip flexion may be a bit weak, but it's not really. It's L1, 2 rather than L2, 3. But of course those are variable. But look for hypertonus in the paravertebrals, or at least in the multifidus, and quad weakness in the lumbus, and quad weakness. If you find, you then look for nociceptive points with this screening test, quadrant testing in the neck, PA. Well, PAs are difficult in there, but you can do those as well. Quadrant test in the shoulder. Sorry, where am I going? Quadrant test in the lumbar spine, quadrant test in the hip. And that'll tell you about nociception and what joints need then to be examined with a biomechanical exam. And if that's found, then you may or may not treat that problem. Okay, so there are other causes, there are other etiologies, but we're going down this route, and you need to review all the other causes of etiology, which you should have had at this point. So there you go, it wraps it up reasonably well. And it's not that difficult, but you just have to keep yourself organised. You can't just fire off all over the place. You can't think, oh, it's segmental facilitation, it's segmental facilitation. It's neurophysiological, neurological, mechanical. So, treatment. Local pathology first. It's got to be treated. You can treat the etiologies by all means, but the local pathology must be treated. It's not going to get better on its own, at least not for quite a while. So, basically, this is inflamed. If this is chondromalacia, this needs medical guidance. If, on the other hand, this is standard retropatellar pain syndrome, we've got some inflammation going on. We can tell that because of the irritability, the aching after exertion, and a bit of the swelling. So there is inflammation present. Otherwise, nociception from this area is not really well understood. There are no nociceptors in the cartilage, and yet it's painful. So I have no idea why, so I'm not even going to get into that. Anyway, we're going to treat it as an inflammatory problem, so we rest it, take them out of the activity, tape it if you know what you're doing with that, but you can use proprioceptive tape and to hold it in position. Interferential currents, ultrasound, as I said to you earlier, high dose ultrasound, rubbing this thing over like 6 inches for a lesion that's maybe 1/4 of an inch in size really doesn't make a lot of sense. So high dose ultrasound and careful grinding techniques where you, again, I'm not even sure what you're doing with this, but it does seem to work. Then you're going to look at the etiologies as well as treating the pathology, local pathology. So biomechanical exam and treatment for whatever you find. Foot orthotics if it's required. If you've got a collapsed foot, you're probably going to have to support that up and take the stress off the valgus, and a knee support or taping when they're running if that's required as well. So This is not the only causes of retropatellar pain. You've got weakness of the glutes, allowing over medial rotation, all that sort of stuff. But this is what we had. This is what we found. This is what we dealt with. So you can sort out the other etiologies yourself, and you should be able to do that now. You should be able to figure out what's going to increase that valgus force, the medial rotation of the leg, and that valgus force. And it's a good exercise for you to go through. I've got two sets of comments to make. One is on technique exam, how not to irritate the examiner too much, basically, and the other one is clinical. So let's look at the what you need to be thinking about during the exam. First off, please do not mention a term like segmental facilitation if you don't fully understand it. I had this on a previous exam years ago, and the candidate brought up the term nystagmus. So I said, okay, can you define nystagmus for me? They gave me a two-word sentence, basically a wonky eye, and that was it. I pushed them, they still didn't know what they were talking about with nystagmus. They couldn't define it. So if you can't define it, you can't identify it, so there's no point in mentioning it. They complained that it wasn't their job to do a neurologist exam, a neurologist's job. They had to do musculoskeletal. My point is, don't mention the term. And it is your job to identify things like nystagmus, because they won't see a neurologist unless somebody does identify it. It was a completely stupid comment on their part, but the easy way out of this is don't mention a term if you don't understand it. Better yet, understand the terms that are part of your profession and use them. If you're going to postulate on something like quads causing increased pressure on the patella, then you must be able to tell me or tell the examiner exactly how this happens. There's no good just saying it, a blank statement, because I don't really understand how this happens. With the knee straight, which is where most of these problems occur in like running, for example, you don't have a full flex knee, so that you really don't get this quad being pushed back onto the femur. This is more like uneven pressures, medial and lateral, rather than up and down, and anteroposterior. So you've got to be able to explain what you're saying when you make a statement like that. So make sure you can, or don't bring it up. There are better explanations for what's happening than that. Also, think about your answer and then give it, all right? Don't hesitate once you said it and go and try and second guess yourself, because you're going to be in trouble. So just think about the answer and get it out, all right? If it's wrong, it's wrong. But if you give it some thought, it probably won't be wrong. But if you second guess yourself, that may well be. And then don't take too long with your answers. It's not to rush this, but don't go off on a tangent. Don't get involved in a conversation with the examiner that's unnecessary. Just get in there, do your stuff, and get out. Now, what will happen is if you spend too long answering questions or doing testing, that's the other thing, make sure the testing is good. But if you spend too long answering questions or doing tests, then there won't be enough time for you to answer enough questions. And if you can't answer enough questions, you're not going to pass. You're going to need 70% on this exam. It's a fairly forgiving practical exam to a point, but you've got to get through it. So if you find yourself only answered 50 or 60% of these questions, even if you get them all right, you're not going to pass. It's really as simple as that. So don't hesitate for too long. And of course, there's also the other thing. The testing is straightforward. Learn the tests, be able to do the tests, learn the treatments, be able to do those, and do it facile. Like I've had people do reflex testing, reflex hammer, deep turn reflexing, and I'm sitting there wondering if this is the first time they've ever had a reflex hammer in their hand. That is no way to go into an exam. Get in there, like, make yourself good at this stuff. Use this in the clinic. Make sure you test everybody's reflexes when you've got a patient come in, so you can do this quickly and easily and you're done with it. What you don't want is the examiner looking at you going, what are you doing? Yeah. So get all that done and get it out, and don't hesitate too long getting it out. I've said it before, and I'm going to keep on saying it until you get this. Organise your processes. Like picking stuff from here and there just doesn't work. Patients are the same. You're going to approach this in the same way, like rationally. It doesn't change. The details changes from patient to patient, from joint to joint, but the principle is the same. So what I suggest you do is, whether you're talking about diagnosis or you're talking about etiology, start off with broad categories. Okay, neurophys, mechanical, and then zone in from there. And use screening tests to rule out areas and get it over and done with. Rather than trying to prove every single pathology that pops into your mind, disprove it, and then when you can't disprove it, then prove it. And that'll save you an awful lot of time. And we go back to the exam comments, it'll get you done quicker. But it's the easiest way to do it. It's much easier to disprove something than prove it under these circumstances. Not always true in the world, but in this case, it is easy. Like a really good sensitive test will get that out of the way, at least provisionally, and you can move on to the next one. Don't try and multitask. Most experts can't do it. I'd have trouble doing this. It doesn't work anyway. The research has shown that multitasking is not possible. You don't multitask. You don't do two things at once. You do one thing and switch to the other thing. And the more you try to multitask, the more tasks you take on, the poorer you do this. Focus on one task at a time. Your first problem is the diagnosis, then treatment plan, local treatment plan, and then etiology, and then a full treatment plan. So focus on what you're doing. If you find an etiology, that's not necessarily the end of it. There are contributors, there are other etiologies, so keep going until you've exhausted the possible etiologies. And don't forget, come from the diagnosis. All right, the diagnosis will guide you as to what etiologies you're looking for. Predict from the diagnosis what is relevant. All right, so what you expect to find, what is relevant, not just a shotgun approach to try and test everything. Make sure you understand terms. All right, you can't go in and say chondromalacia patella if you can't define it. For example, this is an imaging term. Really, you have to see it. You have to see it's either open surgery, arthroscope, or imaging, and then you can diagnose it as chondromalacia. But until that point, it isn't. This is still retropatellar syndrome. So don't get caught up in the terms, because as soon as you did that, Mark, you said chondromalacia. My question to you was, how do you know it's chondromalacia? And you're off on a whole different pathway. You've moved me away from your exam and taken me with you down this pathway. So don't do it, all right? Keep things as simple as you can. You need to be reviewing all the tests that you were taught, talking about this particular case, but this applies to everything. But in this case, review all the tests you were taught, including tracking tests, the Q angle, all the stuff that you appeared not to know, but I'm sure you've been taught. So review all this and get it out there. This is general. You can't know enough anatomy and pathology. You just can't. You can keep studying this and studying it, and you should keep studying and studying it. So I've got some recommendations for you. You need a proper anatomy text. Atlases are okay, but you need more than that. You need specifics. Now, the visible body is quite good for this. It's fairly cheap, it's about $24. It's an online, or not online, or you can get it online, or you can buy the whole thing, but it's about $24 to buy. It costs nothing, and you can dissect it, layer it, unlayer it, rotate it. You can do all sorts of stuff with this. And the anatomy description is not bad. I learned from Gray's Anatomy, and I don't think you can do better than that. But you need a good anatomy book. And for pathology, what I suggest you do is look at medscape.com. It's a medical site, but this is where we're interested in. Biomechanics doesn't have that much pathology that's particularly complex, but you need the medical pathology. And this, I've never been let down by this at all. So have a look at Medscape. It's free, and it's got some really good descriptions of medical pathology, and it's well organised. Strongly suggest you use that.